And as you know, when you write papers in the infancy of any technology, you just publish what it is at the time. And sometimes as you get more data, it turns better. And that's what we're going to talk about. And again, JJ, if you weren't watching, this was a two-level thing we're debating. So the first is evidence-based criteria, right? You know, who are candidates for CDR versus an ACDF, and what is that evidence? And patients who are candidates for cervical TDR are based on the basically a summary of what is the inclusion and exclusion criteria of the studies. That's what we have level 1 evidence for. But is there also evidence for expanded indications, which is not going to be part of this talk? Right now, it's for 1 and 2 contiguous levels, mild radiculopathy, at least 50% height, less than 11 degrees of segmental motion with functional facets, no kyphosis. So we're talking about 1-level disease like this, or maybe 2-level disease like this, which is very close to what Rick showed. And but there's other ACDF indications, which this is not part of this debate, which I think JJ was trying to make part of the debate. Well, we're not talking about this, all right, because I think we can all agree that that's not a TDR patient. So what are the problems? Well, most published literature today shows a lot of retrospective data. So these are at best class 3 type studies. And outcome instruments that are used for success criteria for all the ACDF studies just vary widely. So, I mean, it's really hard to get good data on the ACDFs. Well, what about CDA outcomes? Well, there's an abundance of level 1 data. The interest has led to prospective and retrospective studies. And we've got all these devices out of here, which, again, not part of this.